Between 2001 and 2017, over 53 million infants in the United States were breastfed. Out of those 53 million exposures, U.S. poison centers confirmed exactly 8 major adverse drug reactions linked to maternal medication in breast milk. Despite this safety record, older FDA package inserts default to vague, legally protective language, advising that caution should be exercised when administering almost any medication to a nursing patient. Because of these warnings, maternal medication use remains the leading reason clinicians advise patients to stop breastfeeding during their infant's first year. This clinical reflex to pump and dump is often an oversimplification of the biological mechanisms that actually regulate drug transfer into human milk. Clinicians often assume that a drug ingested by the mother directly equates to systemic exposure in the infant. In reality, true infant risk is a sequential degradation equation. The drug is filtered down at every biological step. The first filter in the sequence is maternal plasma distribution. The second filter is physical exclusion at the lactocyte barrier. And the final filter is the infant's own first-pass metabolism and systemic clearance. To accurately evaluate whether a drug is safe, clinicians must replace fear with a first principles analysis of the drug's journey through this precise biological gauntlet. The absolute foundational rule of lactation pharmacokinetics is simple. If a drug is not freely circulating in maternal plasma, it cannot enter the milk. The primary mechanism that limits this plasma availability is a drug's volume of distribution, or VD. Drugs with a VD exceeding 1 to 3.5 liters per kilogram, like digoxin or THC, sequester heavily in maternal peripheral tissues, like fat and skeletal muscle. By residing outside the plasma, a high volume of distribution starves the mammary capillary beds of the drug. The second major trapping mechanism is plasma protein binding. Only unbound drugs can passively diffuse. Warfarin is the textbook example of how this protects the infant. Warfarin itself is a small molecule weighing 308 daltons, but because it is 99% bound to albumin, which weighs 65,000 daltons, it forms a massive drug-protein complex. This resultant complex is physically too large to exit the capillary fenestrations near the mammary gland. High volume of distribution and high protein binding act as the first massive sieve, preventing the vast majority of a maternal dose from ever reaching the lactocyte. When maternal progesterone levels abruptly drop after delivery, the colostral phase ends. The mammary epithelial cells migrate together. As they meet, they form tight apical junctions, permanently shutting down leaky paracellular diffusion. To enter mature milk, drugs must pass directly through the cell walls via passive transcellular diffusion. This creates a strict physical weight limit. Drugs larger than 500 to 800 daltons, including insulin and monoclonal antibodies, are permanently locked out. For the few drugs small enough to bypass the weight limit, lipophilicity becomes the ultimate gatekeeper. Highly lipophilic drugs, like the antidepressant mirtazapine, easily cross the lipid bilayer and actively concentrate in lipid-rich hind milk. The mature lactocyte acts as a highly evolved physical sieve, neutralizing the threat of large or hydrophilic molecules. Because modern assays are ultra-sensitive, picograms of almost any drug can be detected in milk. We need a way to quantify the actual danger of the molecules that do cross over. The absolute infant dose estimates the daily theoretical exposure based on the milk's drug concentration and the volume the infant ingests. But the more critical metric is the relative infant dose, or RID. This standardizes the maternal dose to a referential weight-adjusted infant-size dose. The foundational standard of compatibility relies on this number. An RID under 10% is universally recognized as the benchmark for safety. This benchmark relies on standard dosing. If a clinician doubles the maternal dose, the infant exposure doubles in parallel. While the RID provides a crucial clinical benchmark, it only represents the drug presented to the infant in the milk, not the drug that actually reaches the infant's bloodstream. Once the drug leaves the breast, it enters the infant's gastrointestinal tract. Drugs relying on protective maternal formulations, like enteric-coated omeprazole, are instantly destroyed by the infant's digestive system. Drugs with inherently low oral bioavailability, like vancomycin or morphine, undergo massive first-pass metabolism in the infant's liver, preventing systemic absorption. This leads to the final critical variable in the equation, the infant's capacity for systemic clearance. This line graph shows reported adverse milk reactions mapped against infant age. You can see a sharp concentration of risk here. 63% of all reported events occur in neonates during their first 28 days of life. This danger window exists because neonates possess only 28% of adult CYP450 protein mass, alongside highly immature glomerular filtration rates. But by month 2, term infants reach 80% of adult renal capacity, rapidly eliminating the risk of drug accumulation. The infant's physiological development acts as the ultimate filter. Once renal and hepatic pathways come online, the true systemic risk of maternal medication drops to near zero. We can apply this exact model to a highly potent drug class to test the math in extreme scenarios: monoclonal antibodies like natalizumab. These drugs have incredibly long half-lives, but their massive 150,000 Dalton weight means only microscopic amounts cross the strict lactocyte barrier. This chart compares the maternal steady-state trough of natalizumab, 23 micrograms per milliliter, against the peak milk concentration, a minuscule 2.83 micrograms per liter. Applying a maximum 5% systemic infant absorption rate to that microscopic concentration filters the drug down again. The math yields a stark conclusion. An infant would have to consume over 500 liters of milk per kilogram in a single day to reach even 10% of the mother's trough concentration. When subjected to rigorous, multi-tiered pharmacokinetic modeling, perceived catastrophic clinical risks dissolved into mathematical impossibilities. Evaluating postpartum pharmacology requires moving past the outdated, overly cautious warnings found in package inserts. Analyzing volume of distribution, molecular weight, and relative infant dose and neonatal bioavailability is the modern standard of care. Human lactation functions as a highly regulated secretion system, actively extracting nutrients while excluding potentially harmful substances from the infant's supply. Replacing fear with physiological data prevents the unnecessary disruption of the maternal-infant dyad. In the vast majority of cases, rigorous pharmacokinetic analysis supports the decision to continue breastfeeding.